everyone. Welcome back. Welcome back. Welcome to the 50th Annual AAKP National Patient Meeting. My name is Jerome Bailey, and I serve as the Director of Patient Engagement and Advocacy for AAKP. In this role, I have the privilege of working directly with patients, care partners, and advocates to amplify their voices on the issues that matter most. I connect patients with opportunities to join national policy discussions, advisory panels, and research initiatives so lived experiences shape the future of kidney care. Together, we remove barriers to care, access, and choice, expand treatment options, and ensure patients are represented at every table where decisions are made. As an AAKP team member, it's an honor to be a part of this historic milestone as we celebrate the golden anniversary of this event. Our theme, 50 proud years of patient education, 50 years of saving lives, 50 years of saving livelihoods, reflects both the extraordinary progress we've made and the enduring mission that guides us. For 5 decades, AAKP has been committed to empowering patients, supporting innovation, and driving policy change in kidney care. This meeting is not only a celebration of our past, but also a look forward to the future we continue to build together. One of the greater patient choice, stronger communities, and better outcomes for all impacted by kidney disease. It's my privilege to introduce our breakout session, Choosing or Changing Dialysis Therapies, where we are joined by a good friend and local Texan, Dr. Samaya Anumudu. Dr. Anumudu is an associate professor of medicine at Baylor College of Medicine in Houston and is board certified in internal medicine and nephrology. She is the director of home dialysis services at Baylor Medicine and cares for patients in multiple clinics and hospitals across the Houston area. Dr. Anumudu is an accomplished clinician, educator, and researcher with focus on home dialysis, chronic kidney disease, patient safety, and public policy. She serves on the board of directors for the Renal Physicians Association, contributes to the American Society of Nephrology's Public Policy and Advocacy Committee, and has published in leading journals, including the American Journal of Kidney Disease and the Journal of the American Society of Nephrology. Please join me in welcoming Dr. Anumudu as she leads us through this important discussion.
Thank you so much, and I definitely want to start off by saying thank you so much to the AAKP and especially to everybody in the audience and online. It's always a pleasure to attend this meeting and meet all of you all, so I really appreciate you. And also, I'm the last talk of the day, I hear. So I stand between you and the last thing. So I really, really appreciate you being here. So today I'm going to be talking about choosing and changing dialysis therapies. And I, initially started broad, and then I'm going to kind of really focus it in. And I was delighted to be asked to talk on this topic because, frankly, I love talking about it. And it's a good thing because it's something you want to continue to draw attention to. And it's positive and it empowers patients and healthcare providers. But it also is a little bit, maybe sad is the right word, because this is something that just should be happening. And the fact that we have to continue to talk about this and how to do it just kind of tells you that we still have a lot of work to do. But thankfully, there's been good research, and I'll talk to you about it, and good science going on, and just a lot of care on both sides of the spectrum that's still continuing to focus on these discussions that need to happen. So with that, the objectives of my talk are pretty simple. One, to provide a brief overview of kidney disease. I understand, we have a lot of patients here, and so you all probably know this, but for anybody who's very new to this, I just kind of wanted to go over the basics. We're going to review the kidney replacement therapies, review various decision-making models. This is going to be the breadth of the talk. And then finally discuss modality changes and how to best navigate such decisions in case you are at those crossroads and or maybe you were in the past. And so we would love to kind of hear that as well. Chronic kidney disease in the U.S. Is a very significant part of what we see day to day. Approximately 14% of U.S. adults, or 35.5 million people, are estimated to have chronic kidney disease. Slightly more common in women and more common in people 65 years of age or older, but I certainly see patients on all ends of the spectrum. The risk factors, most common ones: high blood pressure, diabetes, also obesity, heart disease, and of course, family history. When we look at end-stage kidney disease, this is data from the 2020, but approximately 800,000 people in the U.S. were living with end-stage kidney disease. 69% of those are on dialysis, and 31% with a kidney transplant. So just, right off the bat, you can see from those numbers, we have a lot of room in terms of kidney transplant, and we certainly have a room on lowering this number on dialysis. There's so many patients that are still on dialysis, and hopefully we can, bring attention to the cause and recognize things earlier so we can prevent end stage. The incident rate among men is approximately 60% higher than women, actually. And so when we look at kidney replacement therapies, we kind of break it down into three main groups, and then I was a fourth therapy. One is hemodialysis, and so you can do in-center dialysis, you can do nocturnal dialysis, and you can do home hemodialysis. And then there's peritoneal dialysis, which is another great home modality. It's the one that I personally do a lot with. And then transplantation, of course. And then the fourth option is also patients having the right to not do dialysis, okay? And I think that's a really important part of this conversation as well. So fortunately, we've come a long way. I would argue we haven't come as far as I would like, but I'm hopeful. But you can see in 1924, this was the first human dialysis. It lasted only 15 minutes. The axis was actually based on the lower leg. And now we've kind of, made things a little bit simpler, more boxed and more portable and hopefully more convenient. This is what the initial rotating drum kind of looked like. So again, we've come a long way, fortunately. So in terms of access for kidney replacement therapies, predominant patients will have what we call an AV fistula. It's considered our best and long-term access, and it requires a surgeon to connect the artery and the veins together. It uses your native vessels or your own vessels. Hopefully there's a lower chance of infection, but it does take some time to get to maturity. The alternative is something we call an AV graft. Again, the surgeons connect the artery and the vein, but this time they're using some tubing, some artificial material to make that connection. The good thing about it is you can use it right away, but there is always a risk of infection. And then the more immediate, the one that we see often when things are emergent, are hemodialysis catheters. The hope is that these are temporary, but they do provide a quick, easy access that work right away. They can, again, become infected, clotting, they can fall out, we can have issues put them in, but ideally they are considered temporary or what I call semi-permanent. So there's some that you cannot leave the hospital with, there's some that you can leave the hospital with, but ideally you want to then place a longer-term access. When we look at peritoneal dialysis, this catheter sits in the abdomen. The healing time after the surgery for placement tends to be weeks, but it can be used right away if we need to. This also requires training on the behalf of patients and hopefully caregivers. And so it takes a little bit of time to get used to and get going, and it allows a lot of the ownership on the patients and their families. Versus hemodialysis, most people are familiar with this modality, but certainly we're using the machine to kind of do most of the work. And then peritoneal dialysis, you're using your own body to kind of do the work, and you can, again, use a machine, but you can also use manual exchanges is what we call. And so the part about, a lot of the times the discussions that I have in the office are my patients are at a point where they're trying to decide, hopefully I'm catching them before, but we're talking about, okay, now you need dialysis. What is the best dialysis modality for you? What would you like to choose? And we tend to break that into home dialysis or outside of home dialysis. And so this is something that I kind of often talk to them about, and I break it down, and then they kind of give me options that tends to work with them. But obviously with peritoneal dialysis, it can be done at home. It's considered relatively flexible. It preserves your residual kidney function, also known as your patients can urinate longer, which has been helpful to improve their outcomes. The best part that my patients like to hear is that it does not use needles. And it's a good option for those who work or go to school or have, kids and just need a lot of flexibility in their day. And it tends to work a little bit better for patients that have lower blood pressures or have a hard time tolerating hemodialysis. And on the flip side, hemodialysis can be done in the center, but again, it can also be done at home. It tends to require set days and time, so it's a little bit more rigid in its flexibility. You can travel if you're on hemodialysis, but the logistics of it tends to get a little bit more. And then you are also doing treatment around other people if you're in center, which can be a plus or a minus for some patients. And for the most part, it does use needles to try to get things going. So that's kind of one of the big parts. So that's just a brief overview. Again, I'm sure a lot of people, you all are probably well familiar with this, but I'd like to kind of still go over that for those who are not at that stage. So let's talk about decision making. So there was a very nice study in Kidney International in 2021 that really talked about the importance of decision making, especially in regards to dialysis modalities. And so one of the things in this article specifically talked about was individuals with kidney failure who are yet to start dialysis are often not given enough information to make an informed choice or have their choices made for them. And that's just so striking to me because I just consider that so wild. Like that is just the basis of everything that should be happening. And to hear that patients are not given enough information from their providers is something that we have to do better. And they also talked about in 1/3 of participants interviewing in the empowering patients on choices of renal replacement therapy. This is one of our bigger studies that have looked at this. The majority actually started in-center hemodialysis, and they did not think the decision to start dialysis was primarily their choice. And again, that's just so striking to me because for the person going through dialysis is telling us that they did not think it was primarily their choice. So again, we have to do better. So when it comes to decision-making models, believe it or not, there are models. One is a little bit more of a paternal or paternalistic, and that's where the healthcare professional tends to decide on the treatment. This is what you need. This is what we're going to do. That's it. Hopefully, they will consider the values and wishes of the patient and the family, but for the most part, it's pretty one-ended. Shared decision-making, which is my favorite, is essentially an open discussion between patients and their healthcare providers, and it uses a collaborative approach. And then part of shared decision-making is also informed decision-making. And this is where patients make decisions based on information provided to them by healthcare providers without collaboration on the treatment decision. So essentially, they are making an informed choice. And I say this, that it is in conjunction with shared decision-making because the hope is that through the discussions that we've shared together, you are then able to make an informed decision on your own independently. And so that's kind of why I think they interact with each other. So when we talk about shared decision making, it has certain principles that are important. One, you have to invite everybody who's involved in the decision making. You have to allow information exchange between the patient and the healthcare provider, and also hopefully give them resources. So patient decision aids, or PDAs, are very helpful in this because it also gives you another spectrum to just conversation. Sometimes conversation isn't enough, and some people like to see things visually, or sometimes people just need time to reflect and look back and say, okay, I need to do this. Sometimes not everybody has a computer, sometimes people need things on paper. And so PDAs need to be there, and they need to be in a variety. In shared decision-making, you have to consider patients' values and preferences to better understand risks and benefits of treatment options. Enable the patient to make an initial preferred treatment decision and discuss it with the healthcare provider. And then finally, make and review the final choice decision. So a lot of the times, you have to stop when you're having this discussion and say, what is it that you want? What is the ideal scenario for you? And then that oftentimes helps guide our next decision tree. When we look at it in the literature, there's actually a 3-talk shared decision-making model. One part of it is choice, One part of it is an option talk, and then the final part of it is a decision talk. So in the choice talk, you're essentially assessing the options. You can do it face-to-face, you can do it by email, you can do it by calls. And then you actually deliberate, so that's the option talk, and so you're weighing the risks and benefits, and you're trying to make a decision. And then finally, we come together and actually have the decision part, and then we've looked at everything from before, and then we feel comfortable with the decision that we're about to make. So it's often 3 steps. It's a lot of the times not this, but a lot of times it's fluid, and there's a little bit backwards and forwards. But the hope is that you can kind of move through the models and effectively get to the end. And then we talked about this, but patient decision aids, they do not replace consultations with the healthcare providers, but I would argue that they are extremely collaborative and necessary. They help patients make informed choices and their families. They exist in a variety of formats, so pamphlets, booklets, interactive media, nowadays social media, and hopefully they should be evidence-based, they should be unbiased, and they need to be factually accurate. So the AAKP does a really good job at this, and I included, so they have, and I think these are outside, but these are PDAs from AAKP. And specifically, these ones are talking about conversation starters, questions to ask your healthcare team about changing dialysis therapies, and conversation starter, questions to ask your healthcare team about choosing the right therapy for you. It's very pertinent to my talk, but certainly very helpful. And when you open up the pamphlets, you can see there's questions that you can ask. It gives you ideas. You can take notes on them, but really just another good way. And then there's also now these codes that you can, scan on your phone. So I kind of zoomed into one in particular, because I really love the way the AAKP does this. So again, patient voice, patient choice. You've been hearing about this all day. But the AAKP defines high-quality kidney care as timely patient access without interference to innovations that help prevent and treat diseases and empower patients to remain healthy, independent, and better able to pursue their aspirations, including meaningful full-time or part-time work and a career, a home ownership, starting and supporting a family, and secure retirement. And I think that's just very beautifully worded, but I kind of took out some main words from this when it comes to decision making, right? So you have to care, first of all. The patients have to be very involved, and the healthcare team has to be caring in what they do. It needs to be timely. Oftentimes, we're not given the opportunity to do this on a long-term spectrum, and we're having to do this under the immediate emergency situation. However, timely care is so important, and hopefully we can bring this into a timely timeline. Independence is really important. Independence on the patients, on the healthcare providers, to feel comfortable in what's coming ahead and to feel independent in what they're about to do. It needs to be meaningful, hopefully. It tells them that there's options, there's hope. And then ownership on behalf of the healthcare team, and ownership on behalf of the patient that's going through it, and along with their family. And so when I look at this, I look at something called the 3 C's. So choice, right? Comfort, meaning you have to be comfortable and I have to be comfortable in what we're about to do as your healthcare team. And finally, care. It has to involve a healthcare team. It's not just you, it's not just me, but truly taking care of kidney patients takes a village, and you need to have everybody involved. When it comes to this, when it comes to decision making, you've gone through the spectrum of kidney disease and you've made a choice, whether you've decided to do dialysis or forego dialysis, whether you've decided to have a kidney transplant or not. Is your choice final? And I would say for the most part, no, your choice is not final. Life is a set of decisions, and we kind of go through it, and circumstances change. And so the worst thing for me is to hear that maybe my patient didn't feel like they had an option, or just because they started one way, they couldn't change it. So this is absolutely a journey. Modalities change, life changes, and circumstances change. And so we have to be able to be fluid enough to adjust and move forward. Ongoing discussions in regards to tolerability, lifestyle, and burnout has to be included, and it is necessary. So oftentimes, if I see my dialysis patients, there's a lot of routine things happen, but once in a while you need to stop and say, hey, how are things really going? Like, how are you? How is your family? Like, we get to know your family and things like that, but how are things going? Or my patients have had kidney transplants, and, if they've had issues, you have to take a step back and say, truly, how are you doing? How are your medications? How are you tolerating them? And then see if we can tweak things. Knowledge is power, and advocacy is essential. I have learned this in everything that I do in my career, and the patient voice and the provider voice is so, so important. And if we do not use that, then we lose it. And unfortunately, we can't spread the word. So it is so, so important. And then I would say trust your team. But most of all, if you're a patient, you have to trust yourself. When you trust yourself, we also continue to add to that trust. But the hope is that everybody trusts each other. But please, I hope that people are able to trust their teams. And if you do not, then you need to try to find a better team that is comfortable, that makes you comfortable. So take-home points. There's various kidney replacement therapies, and thorough discussions between patients and healthcare providers are necessary. Shared decision-making and using PDAs can help. Circumstances change, and you can make changes, and your voice and advocacy is so essential. So again, I hope that this was helpful. I hope that it empowers you as the listeners and as the people going through this and who will be treating patients, that it empowers you to take a step back sometimes and have these really important conversations. And the more that we do as a community to raise awareness to kidney disease, the more that we do as a community to bring this to the forefront, the more that we can hopefully have these discussions early on and not on an emergent basis, and guide you through the journey that you're going through. So that's about it. I think this is one of my favorite Nelson Mandela quotes: may your choices reflect your hopes, not your fears. It's always a little bit hard to put a quote in a presentation, but I like this one because it just tells you a lot about your choices, and that I am hopeful for kidney disease. I am hopeful for my patients every day. I'm hopeful for my team. And I just hope for a better future, and I hope that we continue to work at it. So that's it. Thank you.
Great job. Thank you very much. So we have some time for questions. So is anyone from the AAKP team available to? Okay. Jackie's going to help us. So if you have any questions, please raise your hand, and Jackie will come to you to hand you the mic. Thank you.
My name is Corvin Morton. I've had a successful transplant. Back when I was on home hemodialysis, the machine weighed about 75 pounds. I used to have to travel with it on business assignments. Just in case this powerful hydraulic pump fails again and I have to go back on home hemodialysis, things happen. My question to you is, with the computerization and the miniaturization of equipment, do you see the home hemodialysis machine getting even smaller in size and in weight?
Yeah, that's a great question, and congratulations on your journey. And I hope that you never have to go back to that. But I think so, yes. I think we've come a long way. I think we have ways to go, but we are in the process of that. And so there's a lot of newer machines coming out, and certainly the focus of that is to be on the portable aspect of it, and the weight of it are certainly options. So yes, to answer your question, absolutely. It is already, there's things that are already there, and then newer things that are coming on the way that are not everybody's comfortable with in terms of healthcare providers, but the more we continue to see them in action, the better it'll be. So yes, I do think that we have a lot lighter things coming your way.
Hey, thank you for your presentation. I'm Michael Gilchrist, care partner to Christina, and I always like to ask the professionals, if you went into kidney failure, what modality would you choose and why?
Yeah, that's a good question, and thank you for being here. So I have actually thought about this a lot, and this continues to, I think, change all my circumstances. But I initially was more in favor of doing hemodialysis, and whether that would be in the in-center, that I initially started with in-center. But now I have 2 kids, and life is busy. And so for me, I think the home option is certainly there, but I would personally lean more towards peritoneal dialysis, mainly because I just, I have to take into account. And my husband is not a medical professional, and he doesn't do well with any kind of anything. So I think I'm on my own for the most part a little bit. But yeah, I mean that question has changed over time. But at the beginning, I was like, oh my gosh, I don't want to do anything. I just want somebody who's trained and knows everything. But now I trust things a little bit more, and I would like to be independent as much as I can. So for me, I think PD is a great option.
This might be an unfair question. I apologize in advance. I had a preemptive transplant. Is there strife between dialysis centers and those who are in favor of a transplant?
I think, so are you asking me if
there's a conflict?
A conflict?
Yes.
I don't think so.
Okay.
I think the assumption would be that there may be, but the truth is, unfortunately, there are, as I told you, the numbers are so many patients with kidney disease, so I don't think that there's an incentive on dialysis companies to not do that. And in fact, in more recent years, and with recent administration changes, the companies are actually more incentivized now to promote dialysis and transplantation, especially doing it early on. And so for that reason, I don't think so. And I'm hopeful that that's not the case.
I had visited a couple dialysis centers.
Yeah.
Talking about nutrition. And I guess I felt a little bit uneasy with their reception. So I was just wondering.
No, I think that that's good. And I think what you did is very commendable, the fact that you went to the dialysis clinics. And before, pre-COVID, we used to do this a lot and allow this a lot. And unfortunately, that has kind of changed. But I think that that's so important because not all dialysis clinics are the same. I can tell you myself, as the doctor, I choose which dialysis clinics I go to. Just because I am credentialed with certain units doesn't mean that I actually go there, and I certainly don't send all my patients there. So I think that part is really important. And again, that's where I talked about the team. You have to be comfortable with your team. And if that doesn't work for you, if that dialysis unit is not focusing on the kind of nutrition that you want or give you that support, then hopefully we can get you into a place that is actually doing that. And so I think that's a really important part of it.
I have a question. Unfortunately, many people crash into dialysis, meaning they start treatment urgently before they've had time to learn about all the treatment options. After the first urgent period, patients and their loved ones often wonder if and when it's safe to switch. For example, from in-center hemodialysis to a home treatment. What advice do you have to encourage those interested in home options to learn more and not settle for the treatment that they started with?
Yeah, that's a great question, and a very important question, especially in Houston. We see a lot of these emergent starts, or in Texas. I would say the sooner the better, and that's because things kind of tend to just turn into status quo. And so my hope, at least when I see an emergent patient, is we start that conversation right from the get-go. And then I say, okay, when you are going to your dialysis unit, I want you to continue to ask about these questions. And we've tried to put into programs, transitional care units, and so on, where as patients start really early on, you start going over dialysis modalities and so on and so forth. So I would say the sooner the better. And that's also because sometimes if you're crashing into dialysis, you're getting a catheter. And the next step will be the units are going to refer you instantly for a fistula without, again, going over those modalities. And so you want to try to capture that early. But having said that, sometimes patients just need a second. They just need a little bit of time to get used to their new reality. They need to get used to what's going on. And they need to accept what's happening. And then they are actually a little bit more capable or wanting to have a discussion about what's next. Do they want another procedure? Do they want to go through a different surgery? And so I think it's relative to what your patient is doing, but personally, I think it's better to start the discussion early.
Can you hear me?
Yes.
Okay. My question is related to that. You know, you really spoke to me when you talked about how circumstances changes. And also that there's this dialysis burnout. And I don't know if there's like a national average on that or what data is telling you, you know, as a doctor to us. But my question is, we tried peritoneal and I got an infection. And I just didn't know at what point could we readdress that with my nephrologist? Or is that, no, you know, strike out, you know, you got an infection, we have to do it in clinic all the time and, you know, till you get a kidney.
No, thank you for that question. I'm sorry you got the infection, but I would say absolutely that is not a strikeout. In fact, you know, one of the things that I tell my patients and we tell them from the get-go is, listen, there is a chance you're going to get infected no matter what modality, but we just have to catch your infection, treat it, and then keep going. So very rarely do I, just because my patient got an infection or peritonitis, do I take them off the modality. There used to be, you know, guidelines have changed and certain things used to be considered game enders and things like that. And with the absence of being fungal infections, we tend to work our way through. Having said that, again, if it is important to my patient or if it is important to the patient and their care family to stay on PD or come back to it, then that conversation needs to continue to happen, and it needs to happen whenever you're ready for it. So if your doctor has failed to talk to you about it, then please, by all means, talk to them at whatever opportunity that you get. I don't think there's no reason to wait to have that conversation. You could even tell them when they were taking the catheter out and be like, Doc, I really want to go back on PD one day. And that way it kind of stays true. But the more you revisit the conversation and you revisit the circumstances, the better that is. And I'll tell you, I had a patient who was on peritoneal dialysis, was all about it, got an infection, had to switch over. And then the main focus from the get-go was to go back on PD from my patient and his wife. And then went to a dialysis center, got great education, met some of co-patients, and then is all about home hemo. And like, I was like, that was not part of our plan. Like, what happened? And he was like, no, I can do this. Like, I like hemo, but I want to do this myself. And that's just what happened. So again, things changed, but because we continued to have that discussion and education continued, we were able to do that. So I guess a long-winded answer to ask your question is to do it now and do it whenever you think about it, because it's fresh on your mind, and then your care team can work it together. That's it.
Well, thank you again, Dr. Anumudu. Please give her a round of applause.